My name is Ho Shik-shin from Kosin University Gasper Hospital. It is because of God's extra help that I'm able to present at this press conference. I would like to thank the KST for inviting me and to Professor who chaired it. Today's topic is navigating metabolic risk in living kidney donors. First, I give you an introduction. Observation from animal models and the general population has led to the concerns about the long-term impact of the reduced GFR. First, in the rat model, unilateral nephrectomy plus the partial ablation of the remaining kidney resulted in the hyperfiltration of the remaining glomeruli, and it suggests that the sustained single nephron hyperfiltration may have maladaptive consequences by the damaging remnant glomeruli. In the general population, decline in eGFR smaller than a doubling of serum creatinine concentration occurred more commonly and were strongly and consistently associated with the risk of ESKD and mortality. Let's turn to long-term outcomes with kidney donation. First, there are a variety of challenges to studying living donor outcomes. The first is identifying an appropriate comparator groups. A second challenge is determining causation of any findings. Second, there are the metabolic and hemodynamic changes after donation. In prospective study, 6 months after donation, compared with the baseline, the measured GFR was 29% in living donors, but unchanged in control. Kidney donors manifest several of the findings of the mild CKD. In prospective control study, a donor remained healthy with stable kidney function for the first 9 years, but differences in the metabolic and the vascular parameters could be harbingers of adverse outcomes requiring future intervention. 36 months after donation, living donor had abnormalities of bone metabolism, significantly reduced tubular phosphate reabsorption, serum phosphate concentration, and serum 125 vitamin D concentrations. 12 months, living donor had a significant increase in the uric acid, PTH, FGF, and CRP levels. In addition, detectable highly sensitive troponin T levels and microalbuminuria were significantly more common in living donors. Third, there are the conflicting report of the living donor hypertension risk. In a meta-analysis, study shows that the nephrectomy did not increase the prevalence of hypertension. In normal individuals, unilateral nephrectomy does not cause progressive renal dysfunction, but may be associated with a small increase in blood pressure. More recent studies of the living donor compared with the controls have continued to have conflicting results, increased risk, or no difference. In this multi-center study shows that kidney donation was associated with 19% higher risk of hypertension regardless of race. In this European study of live kidney donors and propensity score matched non-donors from the general populations, they demonstrated that the long-term prognosis of people that underwent a live kidney donation is identical to non-donors. This slide shows CVD and mortality outcomes in living donors. All the studies comparing living donors with matched controls found no difference in the CVD or mortality. In a meta-analysis and a review of long-term living donor follow-up studies concluded that CVD and mortality were not increased after donation. The older study comparing living donor with matched control found no difference in the CVD or the mortality. However, most were limited by relatively short follow-up. Most recently, 7 studies comparing living donor with matched controls found either no differences between group or decreased mortality in the living donor. This slide shows the CKD and ESKD risk compared with the controls. 2 studies reported increased ESKD in living donors, but in both studies the absolute ESKD risk was small. A major limitation of both of the previously mentioned study is that they did not match for family's history of CKD. This study demonstrated that kidney donors are at the increased long-term risk for ESKD, CV, and all-cause mortality compared with a control group of non-donors who would have been eligible for donation. Compared with matched healthy non-donors, kidney donors had an increased risk of ESKD over a median of 7.6 years. However, the magnitude of the absolute risk increase was small. A common concern with most previous studies is that there was insufficient follow-up time. The reported interval from the donation to ESKD directly related to the duration of a follow-up. In single-center and registered study, authored a report of 66 living donors who donated more than 50 years ago. Figure 1 shows the overall cumulative incidence of all-cause deaths post-donation and the cumulative incidence by cause. 30% of the deaths were due to CVD, an instance similar to that seen in the U.S. general population. In the University of Minnesota states, mean interval from donation to ESKD was 27 years. A critical question is whether living donor who subsequently developed risk factors for CKD will have an accelerated course to CKD and kidney failure. There are few data to answer this question. Weight gain was associated with increased risk of hypertension and/or diabetes. In discrete data on the serial BMI post-living kidney donation, increasing BMI was associated with a higher relative risk of hypertension and type 2 DM. However, weight gain was not associated with a greater risk of CVD, CKD, ESKD, or the death. This is the first national study to examine risk for ESKD among a quarter of the obese living kidney donors. Each unit increase in the BMI higher than the 27, there was an associated significant 7% increase in risk of the ESKD. Onset of diabetes in the living donor was associated with the development of proteinuria and hypertension. These results indicate that the donor who developed diabetes similar to patients with diabetes who have 2 kidneys and more likely to develop hypertension and proteinuria. These results demonstrated that roughly 1/3 of kidney donors develop the hypertension after donation, and risk factors for its development are similar to what is seen in the general population. Hypertension was associated with proteinuria, CKD, CVD, and mortality. I'd like to tell risk factor for the CKD, ESKD, and risk calculators. Each calculator has a limitation based on the data available in the data set. A calculator that could estimate the long-term risk with and without the donation is still needed. I would like to tell you that the long-term living donor outcomes. There were no difference between group in the microalbuminuria, incidence of diabetes, AKI, hyperlipidemia, depression, BMI, cancer, fracture, and or the kidney stones. Pregnancy is women with CKD are associated with increased maternal and fetal complications. Thus, there have been concerned about the pregnancy after donation. Unfortunately, there remains limited data on the pregnancies among the female living donors. Pregnancy is associated with anatomical and physiological effect on the kidney, including hypertrophy and hyperfiltration. The data shows that pregnancy after donation is not associated with increased risk of complications compared with the pregnancy in the matched general population. Let's turn to a potential mechanism for progressive decline in GFR after kidney donation. First, the underlying disease or disease risk that was present before the donation. One possibility for progressive decline in GFR after the donation is underlying or the subclinical disease in the donor. Analysis of OPTN data found that only a few living donors developing ESKD had the same disease as their recipient. Kidney donor evaluation do not typically involve a kidney biopsy of the potential donors. Careful morphometric study of kidney histology from the biopsies obtained at the time of donation suggests otherwise. Among apparently healthy adults, the microstructures finding of nephron hypertrophy and nephrosclerosis differ in their association with kidney function, macrostructure, and risk factors. Longitudinal investigations are needed to determine the prognostic significance of these structural findings. In the recipient living donor kidney, the test censored graft failure over a mean of the 6.3 years was predicted by more severe interstitial fibrosis and tubular atrophy, arteriolar hyalinosis, larger glomeruli, and larger tubules in the living donor kidney at the time of donation. Subclinical nephrosclerosis, larger cortical nephron size, and the smaller medulla volume in healthy donors mostly predict test-censored graft failure in the recipient, independent of donor or recipient clinical characteristics. Second, the detrimental impact of glomerular hyperfiltration after donation. Another possible etiology of living donor ESKD death is that the resulting glomerular hyperfiltration leads to nephron damage. Early after donation, the GFR in the remaining kidney is approximately 60% of the GFR before donation due to compensatory hyperfiltrations. Importantly, physiologic modeling studied in living donors have suggested that the compensatory increase in single nephron GFR after donation is not maladaptive. It is possible that the abrupt decrease in the renal function associated with the nephrectomy by the somewhat variable age-related decline in GFR may lead to the clinically relevant kidney disease in some living donors. A living donor developing kidney disease starts off with a lower GFR than an individual with two kidneys. Let's turn to the long-term donor care. First, the counseling of the donor candidate. In addition to counseling about the perioperative risk, living donor candidate should be the counseled about the potential long-term risk. Second, the long-term donor care. We have now the run that type 2 DM and hypertension are the two most common causes of ESKD after living donation. And we also know that the treatment of new onset CKD can often slow the progression. Third, the need for the additional study. There are few data on the outcomes compared with approximately matched controlled with sufficient follow-up time to meaningfully assess the attributed risk. This study shows that identifying outcomes that are important to living kidney donors. In this single center study of donation-related concerns, nearly all patients reported personal or the family concerns regarding donation. Concerns from the participants, the social network were common and often differed from the participant the personal concern. I would like to conclude with several remarks. First, there are concerns regarding medical risk to the donors in living kidney donation. Second, some studies report increased the overall mortality, CV mortality, and kidney failure in living donors. However, the absolute risk is very small. Third, studies have not defined the risk attributable to donation. First, there remain critical need for long-term follow-up studies. Last, donors need to continue to medical follow-up and encouragement for a continued healthy lifestyle. Thank you for your attention.